Hi, today we have to discuss atelectasis in this video, and I want to mention that I have nothing to disclose and this video is for educational purpose mostly. Objectives of this video is to review the various mechanisms by which atelectasis occurs, identifies risk factors, discuss the typical presentation, and explain the importance of collaboration and communication among the interpersonal team to ensure patient education on atelectasis, early application of preventive strategies and prompt diagnosis and treatment. Some general information regarding atelectasis, like the word atelectasis is Greek in origin and mean ateles and ectasis, meaning imperfect expansion. So by other words, I can say that when I hear a word atelectasis, I have in thought something like tight, teeny, or squeezed, and of course it is long. As a result from partial or incomplete reversible collapse of the small airways. So small airways are involved and leading to an impaired exchange in cases, and especially oxygen and bicarbonate. Carbon dioxide. And lead, of course, to intrapulmonary shunt, and it means that circulation is okay, is going well, but respiratory function is affected and do not lead to a gas exchange. And another interesting fact is that incidence of atelectasis in patients undergoing general anesthesia is 90%. Etiology by mechanism, we have many types, like compression of the tissue or compressive, abortion of alveolar air, or resorptive and impaired pulmonary surfactant production or function of this substance that is produced by body at the level of the alveoli. Atelectasis can categorize into obstructive, non-obstructive, postoperative, and rounded. Non-obstructive atelectasis classify into compression, adhesive, cicatrization, relaxation, and replacement atelectasis. Compression atelectasis is secondary to increased pressure exerted on the lung, causing by alveoli to collapse. And here is a scheme, or I would like to say a formula that you have to know regarding a decreased transmural pressure gradient. A transmural pressure gradient is equal alveolar pressure minus intrapleural pressure across the alveolus, resulting in alveolar collapse. What does it mean? We have on the left side representation of the graph, like this is a lung, and I made this space too much, but this is intuitively pleural space. Normally it is close to the lungs and close to the thoracic wall. So normally when inspiring oxygen, here will create a negative pressure, like pulling of air, air inside. Air is going inside, and it's done by negative pressure. So when expansion of the thoracic cage is produced in this pleural space, is produced a negative pressure, and it also attract a lung to the same side. In times that when there is pneumothorax or something like that, and here is a communication, and pressure that is positive here become positive also and produce collapse of the lung. In an awake and spontaneously ventilating patient, caudate excursion of the diaphragm during contraction causes a subsequent decrease in intrapleural pressure and alveolar pressure. So normally when patient is awake, he do cavulate excursion of the diaphragm. So diaphragm is located at the lower side of the pulmons, and it goes down and flattens and produces negative pressure and pull down and expand the pulmons. It occurs in normal awake patient. The decrease in pressure allows for passive movement of air into the lungs. So as we talked previously, you are inspiring oxygen on intrapleural space, pressure is negative, and for this reason oxygen is pulled inside the flux and the lung expands to all the directions. This process is inhibited by general anesthesia due to diaphragm relaxation. So when you are applying neuromuscular blocking drugs, you are interrupt this action, synchronized action of the diaphragm, which participates as a main muscle in the respiratory act or respiratory process. So adhesive, second one is compression and adhesive non-obstructive atelectasis is often the result of a surfactant deficiency or dysfunction as seen in RDS or RDS in premature neonates. Surfactant function is to decrease alveolar surface tension and prevent alveolar collapse. And therefore, any alteration of the surfactant-like production or function can manifest as an increase in the surface tension of the alveoli and lead to instability and collapse. So pressure increases and alveoli tend to collapse, like surfactant tend to maintain this pressure inside and do not allow to collapse, instead of lacking effect of the surfactant. So alveoli will tend to collapse and will decrease in size. Okay, cicatrization atelectasis is often a result of parenchymal scarring of the lung and leading to contraction of the lung. Processes that lead to cicatrization are tuberculosis, fibrosis, and any other chronic destructive lung processes. Relaxation atelectasis involves the loss of contact between parietal and visceral tissue, as seen in pneumothoraces and pleural effusions. Replacement atelectasis is one of the most severe forms and occurs when all of the alveoli in an entire lobe are replaced by tumor, and is typically seen in bronchoalveolar carcinoma and results in complete lung collapse. So replacement of tissue with tumor completely, and it means that that part will not participate in the respiration and lung will start to make atelectasis. Obstructive, so middle lobe syndrome involves recurrent or fixed atelectasis on the right middle lobe and lingula. Extraluminal and intraluminal bronchial obstruction can result in middle lobe syndrome. Is rarely seen but is very important. Sjogren's syndrome has associations with middle lobe syndrome, and treatment with glucocorticoids has been favorable. Non-obstructive causes include inflammatory processes, defects in bronchial anatomy, and collateral ventilation. A fiber optic bronchoscopy and bronchoalveolar lavage are the treatment of choice in this syndrome. And long-term consequences of chronic atelectasis include bronchiectasis. And rounded atelectasis is less common and often seen in asbestosis. The pathophysiology involves the folding of the atelectatic lung tissue to the pleura attached and do not move properly. Adults with chronic obstructive pulmonary disease have extensive collateral ventilation secondary to airway destruction and thus are less likely to develop resorption atelectasis in the presence of an obstructing lesion. And postoperative atelectasis typically occur within 72 hours after the general anesthesia and is a well-known postoperative complication. So use high inspiratory oxygen or fraction of oxygen during induction and maintenance of general anesthesia contributes to atelectasis via absorption atelectasis. There is no increased incidence of atelectasis in patients with chronic obstructive pulmonary disease, asthma, or increasing age. Most common in patients who underwent recently general anesthesia, and incidence is more than 90 or 90%, and appears within even 5 minutes of induction of general anesthesia. More prominent after cardiac surgery or cardiopulmonary bypass or any thoracic intervention. Obese patients and pregnant are more likely to develop atelectasis due to cephalodisplacement of the diaphragm. It means that a diaphragm is in this position, and if abdomen is full or pressing up, it will go even upper, because in pregnancy the abdomen is a little bit enhanced in volume because of the fetus, and pressing up the diaphragm and limits the volume of the functional residual capacity of the lung. And the same mechanism is in obese patients. By pathophysiology, administration of general anesthesia and use of muscle relaxants, obesity, pregnancy, inadequate pain control, and any interventions at the thorax increase the risk of developing atelectasis in the postoperative period especially. Atelectasis is seen with general anesthesia regardless of whether or not muscle paralysis is used. One of the exceptions is represented by ketamine. When used alone or only one medication like ketamine, not in combination, it's demonstrated that does not increase the risk of developing atelectasis. Obese patients have decreased forced residual capacity as well as pregnant patients, and decreased compliance. And the last line is inadequate pain control can contribute to atelectasis by inducing shallow breathing or superficial breathing and or inhibiting coughing effect or coughing response. Atelectatic patient is typically asymptomatic but may present decrease or absence of breath sounds like murmur, crackless cough, sputum production, dyspnea, tachypnea, and diminished chest expansion. All of these signs can be seen in patients with atelectasis. A chest X-ray will reveal plate-like horizontal lines in the area of atelectatic lung tissue and is not evident on X-ray until it is really significant or of high area of affected lung. And displacement of interlobar fissures, pulmonary opacification, and tracheal shift toward the affected side. A CT of the chest will show some lung densities and loss of volume in the affected side of the chest. On fiber optic bronchoscopy, atelectasis may be directly visible and can be both diagnostic and therapeutic, often revealing the cause of an obstruction contributing to atelectasis like tumor, mucus, plugs, and foramen bodies, which can be removed by bronchoscopy. An arterial blood gas analysis may reveal arterial hypoxemia, respiratory alkalosis, and normal or low pressure of carbon dioxide. What is the treatment of atelectasis? Most of them resolves within 24 hours after surgery if they are transient lung dysfunctions, and can be prevented by avoidance of general anesthesia and to make a spinal or local regional or regional anesthesia, early mobilization of patient, adequate pain control, minimizing parenteral opioid administration. When a general anesthesia is unavoidable, the use of continuous positive airway pressure, use of lowest fraction of oxygen or lowest possible inspired fraction of oxygen, PEEP or positive end expiratory pressure, lung recruitment maneuvers, and low tidal volume will help to prevent the development of atelectasis. And one study showed that intraoperative alveolar recruitment followed by PEEP 10 is effective at preventing lung atelectasis. Changing position from supine to upright increases forced residual capacity and decreases atelectasis. And we have to encourage patients to take deep breaths and early ambulation, incentive spirometry, use of an a cappella device, chest physiotherapy, tracheal suction, especially if patient is intubated, and appliance of positive pressure ventilation that has been shown to decrease atelectasis. The mechanism of all these measures is transient increase in intramural pressure that allows for re-expansion of collapsed lung segments. Pharmacologic options include giving patients some mucolytic agents like acetylcysteine or recombinant human DNase dornase alpha in patients especially with cystic fibrosis. Nebulized medications, which are particularly beneficial in patients with atelectasis secondary to mucous plugins of the airways, and fiber optic bronchoscopy, as well as in one study, single suction fiber optic bronchoscopy led to improved lung function and revealed reversal of atelectasis in 76% of cases. Bronchoscopy should be intervention when there is a high suspicion of a mechanically obstructed bronchus by different origins and coughing and suction have not been successful or do not resolve the case. We have to make a differential diagnosis with many pathologies like neoplasm, pneumonia, pleural effusion, embolism, or foreign bodies. Complications of the atelectasis, which is one of the most common respiratory complications in the perioperative period, and it may contribute to significant morbidity and mortality. And of course, including transition to pneumonia and acute respiratory failure or ARDS. About patient advices and education. So patient and patient's family education in incentive spirometry and other techniques to minimize risk and produce alveolar recruitment is important. So doctors should do this patient education, and of course even nurses. Thank you very much and have a great time, guys.